Okay, hi everyone. Thanks for joining us. We're about to get started. 30 minutes, one question, one follow-up, and we just have Dr. Williams here today, and I'll turn it over to him now.
Thank you. Good afternoon. And so we'll have a look at some of the numbers, how we're progressing. As I say, overall, we're going in a good direction. I'm not sure I can say the same with the weather, but what can I say? I'm not the weather forecaster. So looking at our numbers here is that we had an increase of 399. That's a 2.21% increase since yesterday. And that means 19,121 confirmed cases in Ontario. Again, the split with the gender is the same as we said before, and a little bit drop there, 44% in 60 years of age and older. And in the Greater Toronto Area, most of the cases have been seen. That's the larger area of about 61% of the cases. Number of healthcare workers, cumulative since January, 3,131. That represents 6.4% of the cumulative number. And we can see Ontario's recovering. In fact, we have 71% of our cases, 13,569, have resolved. And when I looked at the national data, that makes up pretty well half of all the resolved cases in Canada, which is an interesting statistic in that regard. Currently, we have 1,033 people in the hospital. That's just an increase of 1, so about the same. Number of people in ICU, again, pretty well static, 1 up, 220. But the ICU is dropped by 19 down to 155 on a ventilator. So some of those more severe things easing off, the other ones staying steady. We still see deaths, tragically, and in our COVID-19 experience, our data shows we had an increase of 48 deaths, bringing our total in Ontario to 1,477 from the previous report. Our long-term care report is that good aspect is we had no increase in outbreaks. We've had some more resolved. In that case there, we have, unfortunately, 37 more deaths reported related to long-term care of the data before, and that means a total of 1,111 thus far. And we had, of course, historically, unfortunately, also the 3 deaths reported among healthcare worker staff in the long-term care sector. Retirement homes have been staying fairly stable with 70 in outbreak, and this had an increase of a few cases up to 152, or a few cases added to the long-term care retirement home numbers in there that they have added 12 cases there. So that's improving in that regard on that matter. So where are we at? The good thing is that now we're just below 400 again. So in a way, we didn't see this big jump. I should mention in the laboratory testing, same as pattern last week, after we had the dip earlier, we're back up to 15,179 with 13,000 pending. So as we saw last week again, it dipped down on the Tuesday, which was Sunday results, started climbing on the Wednesday and Thursday, and going up even higher on the Friday as those tests get all processed through and are moving in from the field with the ongoing survey of the long-term care facilities. Our positivity rate has dropped again in that regard down to 4.1%, and that's another encouraging metric as we see how it's impacting our population at large, including those in our long-term care facilities. So we have our decreasing positivity rate. We have our overall case rate staying stable, coming down, that slow plateau dropping of the 399. Some of the recent data that they've been trying to do the segmentation of long-term care data, that means the survey data, as compared to the population data, was shifting a bit more to be more closer to 50-50 in that regard. I'll have to get the definite number from them. So it means you're looking at about that 200 range of community cases in there. And again, it's all going in a good direction over 4 or 5 days. So that's encouraging in that regard. The other than that, our surveillance of the long-term care facilities, were well over 40% of them done. We're heading towards 50% by the end of the week, as was our projected amount. and we hope to have it all completed by next week. We're also going through and testing all the staff at the various child care centers that have been opened up and are opening up for the essential workers. So we're going to undertake that as well and complete that by the end of next week, if not sooner in that regard. So that's basically the overall trend and direction. There have been some other announcements related to the, as you know, the next week with the curbside for retailers, as well as the ongoing general messaging. You heard again from the Premier on people who go to secondary residence in cottage areas that you only go for really essential reasons, go for a short period, take all your supplies with you, small numbers, under 5, and not connecting with the local community in that way. And certainly you have to be well and not go up ill as to burden the healthcare system in that community. And wait until things improve when you can be back in that always interesting relationship with the local community that you've established that rapport with over years of going to your cottage community and your area there. So those are the comments overall. And with that, I'm going to take questions from the media.
Okay, we'll move to the phone lines.
Your first question comes from Allison Martell with Reuters. Please go ahead.
Hi. So we've spoken a lot about long-term care outbreaks. I was wondering if you could tell me if Ontario has a mechanism to declare outbreaks at workplaces that are not health-related and what the current threshold is for that.
So our aspect in the workplaces thus far is that when we have one case that would raise suspicion, we haven't moved the metric down to an institution as in a smaller one, like say a workplace in there, because we'd like to sense is there been transmission in there. And generally with workplace, we're talking about a younger population, not the same as we have as residents in long-term care facilities that seem to have a lack of ability to demonstrate those triad of strong symptoms for COVID and the other symptoms such as shortness of breath, fever, and general aches and myalgia and that aspect there, as well as shortness of breath. So we would assume that if there is 2 cases at the same time frame, we would have to work that's an outbreak, and we would declare an investigation on that regard. It doesn't mean a medical officer of health can't start the investigation even sooner, especially if there's certain things that concern the medical officer of health or their staff, that there is increased risk or risk population that they might want to move on and do testing on a more wider basis to get ahead of it on that infection. But if you're having, as we might get now, because we haven't had a lot of workplaces that have returned to work, and if they have, they've had to maintain the 6-foot distancing. They've had to wear sometimes protective equipment in that regard. So we haven't seen all that because if they're following all those rules and adhering, if there was a case in a workplace, that means they probably acquired it out in the community, and there may be that only reason why that's in that workplace at that time. As we go into some recovery mode, and if there's more people in the workplace, then we'll have to look at how we might want to refine that definition in further if it was necessary. But that is our stance at the moment, and as I said, most workplaces should not have outbreaks if they're following all the directions that we've asked them to adhere to during this pandemic phase of our recovery.
Sorry, Allison, I just wanted to remind people, Allison, you're the only one in the queue right now for questions, so if other people want to jump in, otherwise this will be the last follow-up.
I keep going. When there is a workplace outbreak, are you testing asymptomatic contacts right now?
When we're in that situation there, as I said, because we're dealing with a younger group, the usual pattern would be to have people isolate and monitor them if they're contacts in the workplace. So just because you're in one part of the workplace situation and someone in the other department that you've never seen, no contact at all, would you be tested or need to be tested? We would still take that much more of an outbreak type of thinking and investigation at this stage. Would we choose, because there was a case where the medical officer health said, well, even though there are those cordon rules, I'm not sure it was adhered to, and I think in this case I would choose to test a wider group, including asymptomatics, they so could do that. And so we haven't put that stipulation one way or the other. It's up to the discretion of the local health unit and their staff to undertake it as they see fit in the situation, in the circumstances, and of course, in consideration of what is going on in their community, because these are usually people from the community that are going into work.
Next question.
Your next question comes from Mo Fahim with Sister Radio. Please go ahead. Mo, your line is now opened.
Thank you. Can you hear me now?
Yes, we can. Thank you.
Yes.
Perfect. Thank you, Doctor, for taking questions. My question is, so right now we're at a place where we're still kind of what's the word for it? We're still fixing the databases so that they all show the same figures. Basically, they all correlate and they're synchronized. At the same time, this morning, Ontario announced the plan that they plan to employ when it comes to resuming elective and scheduled surgeries and procedures. So, and that specific plan had a lot of criteria, feasibility assessment criteria, and from those criteria, we saw a lot. We saw capacity for inpatient and ICU beds were in it, as well as supplies, medication, rate of COVID-19 cases in the community. So, understanding that the systems, the different systems we have in place right now haven't yet reached the point where they're fully synchronized. How are we going to go about getting accurate feasibility assessments if we don't know which system to use, basically?
Okay, I think if you mean synchronized, I think what you mean, what we've been saying all along, do in our total numbers report with the IFA system and the epidemiological database versus some of the administrative databases, the segmentation of the community versus the long-term care, that is being rectified. I think the hospitals would say most of the time they will be worried about the community cases, because if you're electing or admitting people into the hospital from the community, you'd like to be persuaded that you're not admitting people who are COVID or unknowingly incubating COVID cases into amongst your other patients when they're coming in for an elective and non-urgent type procedure. So I think if that's what you're getting at, yes, we're trying to do that because they're going to look at a number of factors that would affect each hospital in their locale of the community spread that's going on, how much is the prevalence or incidence in the community. If they had a lot of transfers from long-term care, that might be of concerning, but if they don't, there's the PPE requirement, the other aspects of the case mix, and you've alluded to a number of them that I know our hospital sector is always very concerned about, along with the Ontario Hospital Association and other leads, to make sure if you're going to do this, you're not putting the facility and especially those coming in for an elective procedure at any increased risk. So they're looking at a lot of different metrics as compared to what we look at as far as just the population only.
Follow-up?
Thank you. And as a follow-up, so again, back to the plan that was released today for resuming these surgeries and procedures. When it comes to case prioritization, when they do eventually resume, I see that one of the main things, one of the main criteria for prioritization is going to be COVID-19 exposure and virus transmission risk. Can you kind of explain a little bit more how will that affect the prioritization? And kind of like attached to that, does this mean that if we have a patient that's recovered from COVID-19, does that make it okay for them to have elective surgery?
So I haven't read that aspect. The detailed one, I think, would follow what I said in the first comment, as if you're having someone coming from the community where there is quite a bit of community spread going on, that the person may have been inadvertently exposed or has a higher risk of being exposed in an area where they say, we've had no cases of COVID-19 in our community, positive cases in around the catchment area of the hospital in the last 3 or 4 weeks. They would say the chance of that person inadvertently bringing it in and incubating is pretty unlikely. So a wider leniency around doing elective surgery could be permitted, whereas ones that might have been exposed, whether they had been exposed and recovered, because then maybe saying, well, they got exposed, they went on a cruise way back wherever, and that they were positive back in February and March, it's no longer relevant. They may still want to do some testing to rule in and out, so they could do other types of things to satisfy themselves that the person was not posing any risk to the facility, other patients and the staff in an institution that has now been COVID-free, or at least cordoned off in their wards that are concerned for a long period of time to ensure the safety of elective procedures.
Next question.
Your next question comes from John McGrath with TVO. Please go ahead.
Doctor, when we were given the framework for reopening the economy, it was laid out that we would be in 3 stages, with stage 1 starting after a certain period of declining case counts, and we would move forward from there. And now we're talking about reopening some retailers starting tomorrow, and I've just been hearing a lot of confusion as to are we still on the plan, and are we currently in stage 1? And I'm wondering if you could clarify where we stand relative to the plan as it was announced.
So the pandemic plan, the key public health measure, as you recall, was the requirement for people to, except in the family unit or bubble, to stay 6 feet away, ideally stay home, have very little interaction that would bring you in proximity of people closer than 6 feet. And that still is in place at this time. We've been saying up to now, even the very essential businesses, if you really have to be open, like the grocery stores, how are you going to ensure, one, that the public are 6 feet apart? That means clearing up outside, the one-way aisles, different things you can do that. Only so many in the store at a time to do that. How are you going to be sure that your cashiers, your staff, are separated from the public, if not by 6 feet, by a physical barrier and other steps in there? It's still in that pandemic phase plan. The new ones being allowed on Monday, you have to ensure that. If you're going to do a curbside pickup, you don't need a whole crowd gathering the curbside. If you're coming in your car, you stay in your car. You have arrangement with them, you have a booked time, you're keeping the 6 foot distance, you're monitoring all that. That's what we ask you to do. If you can't do that, then we're going to have to say it didn't work out. But we want to be persuaded that you can do that. Some businesses are saying, I don't think I can. I'm not sure I'm going to open up in that perspective anyways. So we haven't backed off on that parameter of the 6 foot distancing, physical distancing, social distancing. We do allow that a person can wear a facial covering if in the happenstance they might have to be for a few seconds close to someone as a reminder and keep them there. But the facial covering is not saying, well, I got a facial covering, then I can stand next to anyone anytime. That's not what the facial covering's for. And so we still want that in there. If you go to phase 1, 2, and 3, the key thing is that are we going to start to allow larger gatherings, larger groupings? So can you go outside your personal bubble in some sense that way there? Is there a low enough community spread and containment that we can say the general sense of exposure in that regards has been reduced to a level that we're saying to the public, you can start to have more liberal activity in there, and some things would follow suit on that, where you can't maintain that 6 foot distance if you may. So we have not moved on that one, which would be the first one going to first stage and second stage. That tends to open up that very much strict measure of home, personal, you say, physical isolation. And how do we move on that? And so we haven't bent on that even with these new ones that are being added in there, because the parameter is you have to ensure that you're going to maintain that if you're going to do that kind of operation, business, or activity in the next number of weeks until we get to that, or next time, until we get to move off stage 1.
Follow up?
Nope, I'm good.
Okay, we're going to move to the next question.
The next question comes from Natasha MacDonald with Radio Canada. Please go ahead.
Hi, Natasha. Do you have your phone on mute? We can't hear you.
Oh, sorry. Sorry, I was on mute. My question is kind of following into the vein of the last question. I was wondering if you have a clear idea of if and when schools could reopen, if they fit into that 3-phased approach, or if it's after the 3 phases. And I'm wondering, Monday the Premier was saying on the radio that daycare and opening schools goes hand in hand with parents going back to work, just logistically. So I just wanted to get your input on that.
So, yes, we've been having discussions, and if you're going to have a setting like a school, imagine that, whether it's elementary or secondary school, how would you make that function with everybody keeping a 6-foot distance all day long? And you can see there'd be some challenges in there. And that's why a lot of it's done by virtual or remote education at this time. If there's some ideas of how to handle that, we're having some discussions. On the daycare one, or the child care one, knowing there's a need for essential workers to be on the job, and that was very much contingent upon having child care services available, they laid out a lot of strict guidelines about those facilities and how they would operate, and cleaning and all sorts of steps and procedures in there to maintain some other barriers, including the masking of the staff and different tools and toys and different things. So there's a lot of rules in there. And so we watched the first 2 or 3 weeks. We have the one outbreak that's being investigated. We're looking at that now to see what were the reasons and aspects in there. The second was just a worker, which doesn't seem to have gone beyond that, but we want to investigate that as well. And furthermore, we want to test all those workers, because they're coming from the community, to see is there a positivity or concern that to appraise the situation and to appease any concerns or apprehensions on behalf of the parents who are having their children attend those child care centers. So they do go hand in hand in a way, because you can actually have some separation and functionality. But if you get into a large school with 500 or 700, 800 students, especially ones with JKSK and that, you can imagine the challenges to do that under the current pandemic restrictions of the 6-foot distancing and maintain that throughout that period of time. So I think it is contingent on a number of things before we're doing that, and we're in active discussions with the Ministry of Education in that regard, and they're looking at ideas, and we're looking at things about how we might, under scenario 1, scenario 2, scenario 3, depending on the data and how the information is flowing at this time.
Follow up?
So I get that it's, extremely complex, but with everything you just said, do you think that June 1st is a feasible or realistic tentative date?
Well, we did want to see our numbers dropping over a 2-week period. We're in I wouldn't say they're hugely going down. They are dropping. They're coming down over the last 4 or 5 days, not precipitously. So it's going in the right direction. So if you take another week and a half looking at that, is that going to be enough for our public health measures table? Looking at other metrics, positivity rate, the R-naughts, a number of different metrics to say, okay, now we're into the recovery phase, we can move to stage 1. Does that give any more greater leniency that would make it more operable for a school to open in some functionality? Because remember, they need to have some lead time to get things up and rolling in that regard. So this can't sort of here one day and start the next. It doesn't work that way. So we're in active dialogue and discussions, but the days are ticking, so we're going to have to be aware of that and make sure there's due notice and planning.
Okay, thanks everyone.